So today's presentation is on iron deficiency anemia. As we understand that this is one of the most common hematological disorders seen worldwide and very commonly seen in India. So much so that we say that almost most of our female population in the reproductive age group and vast majority of pediatric patients are iron deficient. It is a very common problem seen by hematologists, general physician, pediatrician, as well as public health professional. It's so common that diagnostic is imperative and empirical in most of the cases. And there are definite clues which can be seen on a peripheral blood film and a CBC report. These are important and early diagnostic and easily available diagnostic techniques are there, which Dr. Manoranjan will be highlighting today. Treatment is easily available in most part of the country, uh, almost free of cost in almost all the government hospital and in most of the other facilities, very cheap. But still, the deficiency is very common, and sir will be discussing about the recent updates, the common diagnostic techniques, the recent updates in the diagnosis and the management of iron deficiency anemia. Over to you, sir.
Very good evening to all of you. At the outset, I would like to thank ICGP for organizing this event, the master class, in very important topics. Last time we have discussed the approach to anemia, which is also a very important topic. So I think it continues to that. In next 30 minutes, I will try to highlight few points on iron deficiency. I think I have to change this slide. Okay. So in next 30 minutes, I will just have an overview about iron homeostasis, how iron metabolism occurs, how the iron observed and help in iron in hemoglobin synthesis, and possible pathogenesis or etiopathogenesis of iron deficiency and iron deficiency anemias, the common causes usually see. Of course, the differential diagnosis, as we know, the iron deficiency anemia can present with microcytic hypochromic anemias, and what are the possible differential diagnoses you normally consider before diagnosis of iron deficiency anemias, and of course, the clinical laboratory approach and investigations, and finally, possible iron replacement therapy, which is commonly used nowadays, and pros and cons of oral and parenteral iron therapy. So as you all know, iron deficiency anemias, before going to iron deficiency, I should just mention, because last time we have discussed anemia, anemia is a major problem in a country like India. As we all know, the anemia is defined when there is hemoglobin levels is decreased significantly as per the age and sex, and also red cell concentrations. And red cells and hemoglobin is very essential for blood supply, for the oxygenation of our various tissues. So primarily, anemia is not a disease, and rather is a expression of underlying conditions. For example, patient may present with anemia at various regions. So you should look for what is the cause for anemias. So be it iron deficiency or any hemolytic anemia. So as per the WHO criteria, as you all know, the iron levels which you need to monitor before defining iron deficiency anemia, as mentioned here. So iron deficiency anemia is the most common nutritional anemias or most common cause of anemia worldwide. So be it not only India, so it's one of the most common cause of anemia worldwide. And 20% of the world population is iron deficiency. And that means 1/4 of our populations suffering from iron deficiency anemia. So that's so common. So usually not it's common in low middle economic countries like India, but it's also common in Western world. Maybe the etiology factors are different, where we normally see in India the parasitic infections, inadequate intake, whereas maybe blood loss and other conditions are common in Western world. So it's common in all ages, especially in where the demand is more, like in children and in women bearing age, but it can happen especially in older people and any other ages, and almost all time, most of the times it's secondary to conditions, maybe increased demand or maybe increased blood loss. And chronic blood loss is one of the important cause in adults that should be, I think, should understand. So with this background, if you think the iron metabolism. So as you know, the iron is an essential element for not only for the iron production and also for the some of the enzymes and also its other tissue metabolism. So if you see the total body iron, it's around 3.5 to 4 grams, and two-thirds of these irons present in the red cells, that is the erythrocytes or hemoglobin cells. And majority of the red cells, when destroyed after 120 days of life, half-life is destroyed. So around 0.8 of the RBC destroyed every day. So the red cells are destroyed in the RE system of the destruction, and subsequently this is again observed and reutilized in the production of red cells. So on an average, 20 to 25 milligram daily iron we need to have a normal activity of the red cell productions. And so there is always a balance between absorptions and loss. If you see normal in persons, the normal absorption around 1 to 2 milligram per day, which observed in the intestines, and also utilize and loss. The loss may be various sources. This is the normal phenomenon. And some of the iron also stored, body stores like in form of ferritin or hemoglobin, and of the iron is also present as a form of myoglobin and other specific enzymes. So on an average, this is a common routine iron balance. So once the iron observed is in various forms, usually in the duodenum and proximal duodenums, and they usually are observed in three forms, in maybe ferrous, ferric, or heme. There are three separate pathways by which this iron is observed through intestine and subsequently utilized in red cell production all in the bone marrow. If you go to some other extent in this part, because red cell, most of the iron normally is maybe inorganic iron or a heme iron. The meat eating people like in the Western world, the iron deficiency is not so common as compared to countries where there is vegetarians are more. So that means the heme iron contains, and the absorption is very, very high as compared to inorganic irons. These iron substance usually maybe iron absorption decrease significantly, especially the ferrous and ferric iron or inorganic form by some of the factors like phytates or oxalates, phosphates, carbonates, all these things if you combine, these can reduce the absorption of the iron. Similarly, some substance can like ascorbic or ascorbic acids increase the absorption of non-heme iron. But these inhibitions or decreased absorptions or increased absorptions, this is unaffected by heme iron. Because if you see the structure of heme and non-heme iron, these both are types of cis coordinating bonds. And these, out of the which in heme iron contains 4 pyrrolines. So these 4 is usually observed. This is the features why the heme iron is exempted from these relations, and subsequently the absorption is significantly increased as compared to non-heme iron. The second most important component of iron is, once if you see that this cartoon again, if you see the part A, the iron, the normal hemostasis, the normal metabolic path of iron, the non-heme iron present in enterocytes and maybe macrophage after gestation red cells, there are iron metabolized and deposited in these enterocytes and macrophages, and subsequently non-heme iron is transported across seroprotein, and bound to the transferrin. And subsequently this goes transported to the bone marrow, and there is the production of promoter of erythropoiesis in the red cell. This is a normal cartoon. Okay, so normal enterocytes and macrophages, red cells, seroprotein transferring subsequently iron and red cell productions. But what happens in iron deficiency? There is no iron load, so there is no iron metabolism, absolute deficient state. There is less iron in the transport to the bone marrow, so resulting in less number of red cells formations. And sometimes you can have a functional iron deficiency or iron metabolism in the functional iron deficiency state. So there is, for example, an hepcidin disables the seroprotein, The subsequently iron is enterocytes and metabolized deposited, and but there is no iron for the transport to the erythropoiesis. So there are few things you should know before discussing iron deficiency. As you know, so coming to the pathogenesis, so once you know the iron absorptions and is utilized in its various processes, especially red cell productions, the common pathology is usually the increased physiological demand. The common time where the increased demand is the puberty or children with growing age or women with reproductive age or patients with women with pregnancy and lactation. So these are the time where the iron requirement is significantly high as compared to normal adults. The second most important component of iron deficiency is blood loss, especially pathological blood loss, especially in postmenopausal women and adult males. As you know, the 60 to 70% of our body iron present in the hemoglobin. So once you know the why this part, which is the bleeding, that is why there is significant loss of iron deficiency state, or iron loss on leading to iron deficiency, because if you know the each gram of hemoglobin contains around 3.4 of iron, and if you lost each ml of blood loss from body, if you see a normal person with 15 gram per deciliter hemoglobin levels, that results in the loss of each ml blood, there is a 0.5 milligram of iron. So there is a significant loss. If it is a continuous blood loss, there is also simultaneously we are also losing a lot of iron. So that leads to iron deficiency state to start with, subsequently iron deficiency anemia. So normal persons, a normal adults, has a tissue iron reserve sufficient enough to at least replace 1/3 or 1/2 its circulating hemoglobin. So it's not like sudden blood loss will hemoglobin will suddenly drop, and it can come up subsequently if there is even without iron therapy. Yes, because we have a sufficient amount of iron reserve in our body. But if it's persistent and no replacement is given, then subsequently leads to iron deficiency. That I think we should know that why there is blood loss is important. Third important category is inadequate intake, especially which are not taking proper iron, especially infants with only milk or with cow milk, young children with milk as a poor source of iron, as you all know. And of course, another important component is iron absorptions, a lot of genetic causes for the iron absorption defect, or GI causes like other celiac disease and other conditions. So with this, if you go further, same thing again, what if you see further the different categories, apart from iron requirement, as I have discussed already, like growth and pregnancy, so the regular blood donation is another component also in which a significant blood loss regularly, those are doing blood donation regularly. But if you see the chronic blood loss, there's various causes. The common cause we are worried about the malignancies of GI tract, especially neoplastic conditions like adenosarcoma or coli, and also of the inflammatory conditions, ulcer disease, septic ulcer disease, irritable bowel syndromes. But which is more common in Indian settings, especially in villages, is parasitic infections. So from that we should not forget, okay? Because normally we should also look for a stool routine to look for a parasitic infection that can cause iron deficiency, especially. Other than that, the other causes of blood loss, especially patients with hematuria and other bleeding manifestations, sometimes PNH can present with iron deficiency anemia if not diagnosed before. These are all rare conditions. But other than blood loss, the second most important, the malabsorption syndromes, maybe hypochlorhydria like atrophic gastritis, H. pylori, iron chelations like drugs like tea, coffee regularly, and enteropathies like celiac disease, as I've discussed, and Crohn's disease and other things. The most important part, others associated with anemia chronic disease, is also different component points you should understand, because most of the times anemia of chronic disease associated with iron deficiency anemia. So that is again very difficult to differentiate these two, even if it's a lot of newer developments are going in this field. So apart from blood loss, again coming to etiology, one of the important factors is iron absorption defect. So around 3 to 5% of iron deficiency anemia, they are not responding to or many patients not responding to iron therapy. We should also investigate them for iron absorption defect like this report to gastroenterology, not only for the look for blood loss, also to look for uh, taste like celiac disease. So we should screen for them for serologically on small biopsies. Especially most of the patients present with adult and postmenopausal women, it is also essential to look for endoscopy, to look for any blood loss areas and colonoscopy and colonoscopy, or sometimes CT angiography to rule out any blood loss in this group of people, and subsequently maybe a capsule endoscopy to confirm these conditions. So with this in background, if you see a basic approach of iron deficiency anemia, so iron deficiency anemia, like in any other anemia or any other conditions, it should have a detailed history and examination, and of course, basic tests to confirm the diagnosis apart from a complete hemoglobin blood count. So in history, we should know what are the duration of illness, especially in iron deficiency anemias. Post-bleeding sometimes can have a normal hemoglobin levels, but we should know what is the duration of iron deficiency. Sometimes it indicates a chronic blood loss or a chronic anemia. That is another condition. So especially diet histories, especially history of malabsorption, diarrhea. So that is the important point that is related to history in iron deficiency anemia. Apart from that, many times other chronic diseases that can be associated with iron deficiency anemia. That is also important to consider while taking a detailed history to evaluate the cause of anemia. Of course, this is next step is to look for a complete blood count along with red cell indices, especially MCT, MCT, MCSC, and peripheral smear, of course, to look for not only the classical feature of iron deficiency anemia is already there or not. Many times you will see that microcytic hypochronia anemia is usually last spot. Many times you will have iron deficiency, but maybe microcytic hypochronia not there is usually last spot. So many other findings to clinch iron deficiency without anemia. So before going investigation, if you see the clinical features, so there is not much of difference in clinical features like patients can have signs and symptoms related to anemias, maybe acute onset or chronic onset. So patient can have a normal symptoms like lethargy, fatigability, okay, weakness, generalized weakness, fatigability. There are common symptoms in chronic anemias, but sometimes if there is acute loss, acute blood loss, there may be chance of sudden breathlessness or breathlessness exhaustion. These are the points you should consider. And not only for that, also we should look for the same signs symptoms related to the disease. So many times patient can have a malignancy. Many times patient can have any other condition of the bleeding menorrhagia in child, maybe patient's woman. So that history should be maybe there with iron deficiency anemia. That it should be taken while evaluating case of iron deficiency anemia. Some of the signs symptoms may be classical, maybe signs like in the pictures here in the chylomicroneas. It's there, then it's very classical of iron deficiency anemia. Sometimes you can have a history of maybe pica or maybe abnormal craving of ice or old foods. So these are all sometimes classical symptoms you can have to have a diagnosis by taking a history or examination finding maybe iron deficiency anemia we are dealing with. Apart from signs related to anemia, you can have epithelial tissue changes, especially nail, tongue, mouth, hairs. So that is usually can have a thin luster, brittle, flattening of nail, platinacea or coilonacea, tongue may be atrophy. So these are all signs of nutritional deficiency that we should always see, because iron deficiency may not be alone nutrition deficiency. You can have other combinations of nutritional deficiency in the patients. Usually you don't see splenomegaly, but it can persist. Sometimes it is iron deficiency is very may occur sometimes in severe persistent or untreated iron deficiency anemia. Most of the times it is a cause of iron deficiency anemia, especially if you have splenomegaly, you can go for any GI loss, secondary to portal hypertension, and things that we should always consider in. So apart from them, I'll just put a word about this Lamar-Vincent syndrome. It's very Patterson-Kelly syndrome, sometimes you can say. So this is another clinical feature, very characteristic of iron deficiency. So it usually happens in a chronic iron deficiency with patient can complain of dysphagia, often with gastritis, common in elderly women or middle-aged women. So what we see sometimes have a quicker constriction of the entrance of the esophagus due to epithelial desquamation of epithelial cells, and that's classically says post-recovered with radiologically, and iron therapy alone improves the dysphagia. So I think we should understand, we should know about these conditions. Sometimes they can present the symptoms and features of this syndrome, and increases usually post-recovered customer. That is also important point we should know. So we should treat early in these cases. So coming to the diagnosis subsequently, what we'll do once we have a history and a baseline investigation, especially hemogram to suggest suspect. So first and foremost to look for the red cell indices, that is MCV, MCSC, MCH. So it's usually common and low in these microcytic hypochromic anemia, microcytic hypochromic anemia. And other than that, we need to know, we should do the serum iron studies, especially serum iron, CIBC, and transparent saturations. And of course, look for the stores of serum ferritin, which is maybe earlier signs. And also sometimes bone marrow is sometimes iron absent, and also see a response to therapy. So these are maybe response to therapy diagnostic indicator. Many times note the investigations, patient is anemic, we blindly give iron therapy, and we see the response in 4 to 6 weeks to normal red cells. So this is again a diagnostic assessment. Okay, so these are the headings I think we will discuss subsequently a few slides on this. So apart from red cell indices, as we all know, the diagnosis iron deficiency, the most important useful marker is the iron store that we can assess by doing a serum ferritin, or this is a useful marker. So apart from that, when the conditions, when there is a lot of ferritin mass, for example, in anemia of chronic disease, maybe transparent saturations may be helpful. It falls normal ferritin group of patients. And of course, we should look for the response to iron therapy and look for iron deficiency anemia if there is good response to iron. So most common parameters with red cell iron deficiency is, I think, MCV, which is significantly low, serum ferritin is significantly low, and of course, transparent saturations, which is also significant. So few part about the red cell indices, as you know, we usually see a microcytic hypochromic anemia. So with CT, MCS, and MCH all will reduce significantly. So MCT sometimes reflects the average values and may not be adequately tested blood samples when there's a mixed population of cells. As I've said, microcytes you will see in the end. So sometimes you will see in the early part maybe a normocyte. So there's a mixture, the MCV will be not a good indicator to start with. Sometimes other parameters like red cell width, which again is helpful to differentiating some other causes of microcytic hypochromic anemia. So usually quantify the red cell volume heterogeneity in this group by assessing the red cell distribution width and then the indication of cytoswitch or variation in cell size of these group of patients, because as you know, different populations of cells you can see in these group of patients. So again, red cell width is another indicator which can differentiate from anemia of chronic disease, or thalassemia trait and microcytic anemia, especially in iron deficiency, in contrast to thalassemia trait when ideally RAW is high. So coming to the microcytic anemia, as said, the iron deficiency anemia is the most common cause of microcytosis or low MCT. So, but other condition also we should know where we can see a microcytosis or a microcytic hypochromic anemia, like thalassemias, other hemoglobinopathies, anemia of chronic disease or chronic inflammation, and of course, such sideroblastic anemia. So these are the common routine differentials. So by doing a serum iron studies, how to differentiate other iron deficiency anemia as compared to anemia of chronic disease, thalassemia, and sideroblastic anemia. As you know, iron deficiency anemia, the serum iron percentage saturation, and of course, ferritin is significantly reduced and pH increased. Anemia of chronic disease, although serum iron will be also reduced and the percentage saturation, sometimes you see the ferritin is high. Okay, so that is the other newer mode now to differentiate these two conditions. As contrast to thalassemia, the most of the things normal and ferritin will be high in the group of patients, and sideroblastic is similar. But some of the points also we should know the iron deficiency anemia is passes through different phases. So to start with, depletion of the iron store, then iron deficient erythropoiesis and iron deficiency anemia. So by the time the iron deficiency anemia occurs, microcytic hypochromia you see this passes through these two phases: iron deficiency erythropoiesis, iron deficient store, and normal. So if you see the normal values here, so in first phase, iron store depletions, you only see the bone marrow iron store will reduce significantly or maybe less, ferritin will be low, and maybe TIBC is high. And subsequently, you see iron deficient erythropoiesis, and there is other iron studies, especially myrocytoblast or RBC protomorphin increased, and subsequently microcytia. So there is a difference here. So different parts, whether you treat the iron deficiency state or not, when there is no anemia, that is a point of discussion, and subsequently we'll discuss this one. So apart from that, the other points, if you see other insights to the iron deficiency, the most important differentiating point in these two is iron deficiency anemia of chronic disease. Okay, and sometimes we see iron, at that point I already discussed iron deficiency, so there is normal hemoglobin. Other thing is normal, only these iron stores reduced. Okay, and subsequently they iron deficiency anemias, and it is also important to differentiate anemia, iron deficiency along with iron deficiency anemia or anemia of chronic disease. So that's the test. Now test lot of tests we do, like serum transferrin receptors. Transferrin receptors, also through TFR or log ferritin. They are also important to differentiate these two, anemia of chronic disease and iron deficiency anemia, and also when there is a combined with iron deficiency anemias, FCD is also a marker, and also reticulin content of the hemoglobin, reticulocyte hemoglobin content of this group of patients. So these are all parameters we should know to differentiate anemia, iron deficiency anemia, and iron deficiency anemia along with anemia of chronic disease. So coming to the approach, once you know the microcytic hypochromia anemia, we know MCV is low, ferritin is also low, most likely we are dealing with the iron deficiency anemia. But if this ferritin is very high, not more than 100, so look for other conditions, and non-iron deficiency or should investigate further. If it is in between, less than 45 to 9 ferritin level, so there is a borderline ferritin, and there is no significant flow, that is less than 100, then also do serum iron studies like increased TIBC, decreased saturation. So these are all indicator of iron deficiency anemia. So sometimes TFR will help you. Transferrin receptors levels will help you. If increase, again suggestive of iron deficiency anemia, the decrease non-iron deficiency anemia. So that is also in borderline results. Then I think we should look for the bone marrow iron to confirm, and other than that. So this is the routine investigation plan on to approach and suspect iron deficiency anemia by doing a, after the normal microcytes is in the periplasma, and doing a serum ferritin level to look for the iron stores. Some of the newer diagnostic tools to delineating iron status, we should also know, because this is again a format of approach. Once you know the anemia is there as a WHO classification, then also you always look for the reticulocyte proliferative index. If it's low, then at least transferrin saturation, TF saturations, and ferritin low is most likely iron deficiency anemia. Same thing, again different thing. And if it's not there, more than 100 ferritin, again anemia, maybe inflammation. This is to differentiate to assess the stores of iron. And if it's in between, then we should look the serum transferrin receptor log ferritin levels. It's more than 2, and sometimes hypochromic percentage and reticulocyte hemoglobin content is less than 20. It's most likely we are dealing with iron deficiency with anemia and inflammatory anemia of chronic disease, anemia of chronic inflammation. There is a combination. There is always a difficult to differentiate these two conditions. The newer tools, as you know, the hepcidin is another test, or the marker, protein, it provides liver is an important Nowadays, we know a lot of things about iron metabolism, the role of hepcidin, but sometimes it helps. Hepcidin levels helps to differentiate or distinguish iron deficiency and anemia from ACI or anemia chronic with concurrent with iron deficiency anemia. So when at least the hepcidin is 4 nanomole cutoff to distinguish these two, sometimes fasting morning hepcidin levels again 2.4 nanomole useful cutoff mark to distinguish between anemia of chronic disease in patients with anemia, iron deficiency, or without iron deficiency. Of course, hepcidin usually use look for the IRIDA, especially if the concentration is very high. And with iron deficiency, then I think we should suspect IRIDA, look for the genetic test to distinguish in these conditions. So I think if it's a test, we should also. So with these, now we'll go to the approach, clinical approach, how to do once you know the iron deficiencies. The first and foremost thing is to treat and simultaneously look for a etiology or etiological cause. Especially as you had already discussed, deficient intake or increased requirement, or look for absorptions or blood loss, a defect in the GI tract. And we should eliminate cause simultaneously possible to have any response to iron therapy. Otherwise, if whatever iron therapy will give, that will again, if the blood loss is going on, it will not have any impact on the treatment outcome. And administer iron at least sufficient time. That means not only to improve the anemia, also you should give sufficient to at least require 3 to 6 months to continue iron, so that I have the iron store. Now to look for the response. If there is no response, we should think of other diagnosis or look for the cause. So coming to the treatment part, okay. So once we know the diagnosis is confirmed or plan out our investigations. So we normally don't, we plan to give prophylaxis. So those are a vulnerable group, like as you know, the pregnant women, patients on lactation, children on growing age. So we required to give a prophylactic iron therapies, especially some of the studies to give regularly, and we will normally give these patients with high risk patients with iron deficiency anemias. Once a diagnosis is confirmed, then we should give treatment, usually with oral iron therapies. The dose in elementary iron around 3 to 200 mg of iron, elementary irons, and dose maybe in child 3 to 5 milligram per kg per day, and simultaneously we should look for underlying cause. If you see the oral preparations, the common standard preparations usually ferrous sulfate normally used, but you can have succinate, gluconate, fumarate, and other drugs which are available nowadays. The aim is to give elementary iron. Standard protocol is to give a standard high dose of iron therapy at least for 3 to 6 months, and in children maybe 1.5 to 2 or 3 to 5 milligram per kg elementary iron. But really, because of the side effects of these drugs that can cause adverse predominantly GI symptoms, so that leads to non-compliance of this. So we should take between the meals and inhibitors of iron absorption, especially calcium containing foods such as dietary foods, tea, coffee should be avoided in the iron therapy. And once you given iron therapy, we should also look for response to treatments. And on average, we usually expect iron deficiency and proper iron therapy, the rise hemoglobin around 1 gram per deciliter per week. And in a time around 6 to 8 weeks, we see normalization of hemoglobin in these group of patients. But those are apart from oral iron therapy. So we also understand we have the iron preparations, various preparations available. We'll discuss in detail in subsequent slides. So before going to the oral, so always you should start treatment along with investigating the cause of anemia. That can also significantly improve the hemoglobin levels. Alternate oral preparations And of course, there is no iron, not tolerable to oral iron. You can think about the current like iron to be considered. Most of the times, the red cell transfusion is not necessary, provided a patient is hemodynamically unstable or a sudden fall in hemoglobin levels due to the acute blood loss. Otherwise, we should avoid blood therapies, blood transfusions, and continue on iron therapies. And at least, as I said, at least we should give 3 to 6 months to replenish the iron store. So why I'm saying it's because sometimes alternate therapy and helpful is that compared to trial, there is a randomized trials as compared to 31 patients receiving 16 grams of elementary iron twice daily as compared to while 31 patients receiving alternate arm received 120 mg iron alternate days. So there is a significant, there is not much of, although the hemoglobin rise, 2-gram rise, hemoglobin rate significantly more with the BD arm. That means once you give high dose, there is always a chance of early rise, which are 3 weeks. And also significant rise is median hemoglobin. Once you use in at 3 weeks and 6 weeks as compared to alternate arm, is more in BD arms. But what about after the end of 6 weeks, there is median hemoglobin rise, alternate arm 6 weeks is not significantly different as compared to BD, that is in 3 weeks. So at least patients you can have a alternate day therapy, at least you can have a response as at least the end of 6 weeks of therapies. So you should not worry about if there is side effects. You can at least give some iron orally because iron absorption is usually proportionately high in iron deficiency anemias. And mostly iron deficiency prefer oral iron therapies most of the time. So what are the non-IV iron therapy we have? Because this is most of the times many patients now are getting IV iron therapy, especially the drugs available are a little bit safer as compared to previous drugs which are IV iron therapy which are used, especially ferrous maltose and other drugs are available nowadays. These are all usually can give IV over the period of 15 to 30 minutes. Maximum iron therapy can give at least 35 to 750 to 1,000 milligrams. So what are the pros and cons of IV iron over oral iron therapy? As I've said already, oral iron therapy is usually available over the counter, very convenient to use and routinely used most of the times, and is usually inexpensive and effective when there is intestinal absorption is not impaired and patient is a normal persons with only with iron deficiency anemia. But the major concern with oral iron therapy is limited daily intestinal absorption results in slow iron depletions. So there is a delayed in iron store and dose-dependent GI side effects, especially nausea, vomiting, and abdominal pain and constipation. And uptake also impaired in setting of other iron absorption defects. So in these things, there are problems with iron deficiency, iron oral iron therapy. But most of the times you prefer oral iron, and you should also use oral iron because absorption is very high. Especially intravenous iron, you can have a fast distribution iron source, as I said, and patients can be used safely nowadays because of the newer iron therapies, IV iron therapies, and especially in patients with iron absorptions, you can effective with IV iron. The major concern with IV iron is request by the health professionals, patients used to be admitted in the ward or at least in daycare to use and monitor them regularly, and potential of iron overload transiently continues to give, and potential anaphylactic reactions, especially in iron-based therapies. So what are the indications of IV iron therapy? The established indications, as I've already told, the patients with oral iron intolerance, all iron refractoriness when there is a patients with gastrectomy or renal bypass surgeries, okay, or inflammatory bowel disease, or patients need a quick recovery, especially in severe anemia in second, third trimesters, require a quick iron depletions. Chronic bleeding is not manageable with oral iron therapies. And of course, patients with anemia of chronic disease, like especially in kidney disease, patients with erythropoietin can add iron, IV iron, this group of patients. The potential indications anemia of chronic disease without ACA, but many times you are using, especially in a nephrologist, and potential indications in insufficient supporting data, especially in patients with heart failure, transplant data is coming up, but there is not supporting of iron therapy in the group of patients. But what about the indications? So we should plan early and switch from oral to IV if there is an indication is there. But most of the times, oral iron is sufficient for iron deficiency anemia. But once you know the cause why you have to switch to the oral iron therapy, IV iron therapy should be done as soon as possible. So still, if there is anemia, in spite of all therapies, we really see sometimes there is no adequate response. As I said, what do you mean by adequate response? If there is no rise in hemoglobin, though no retic response in 7 to 10 days, or there is no hemoglobin rise at least 1 gram per deciliters per week, and there is no improvement of iron to normalize in 6 to 8 weeks, we should think about what are the possible conditions. The major concern in iron deficiency anemia is compliance with drugs, especially in oral drugs. Many times they don't take because of the side effects, so compliance should be confirmed whether it's taking regularly medicines or not, and adequate dose. Most of the times, iron medications have a lot of concurrent medicines or drugs or diets that can hamper the iron absorption. That should be checked, especially food habits. And of course, you should always look for ongoing losses. Even if the first time it was negative, especially occult blood negative, we should reconsider and look for loss again, because it is essential to look for losses multiple times, especially endoscopies. And if there is not there and occult blood is still positive, we should investigate them. Malabsorptions, look for and diagnosis to be revisited. That means what other diagnosis you can possibly in this. So in this, I think I will summarize, because what are the other conditions you can think about? Okay, if there is anemia and iron deficiency. So this is, you see the iron deficiencies, most of the time they summarize the iron deficiency. To see the inadequate intake, the most common cause in younger age, special patients and breastfeeding, low birth weight, gout spots, vegetarian diet, absorptions, celiac disease, autoimmune gastritis, genetic conditions like ARIDA, when there is a mutation causing increased hepcidin and iron absorption defect. And of course, erythroid precursors, defect in heme synthesis, iron acquisitions, apart from hemoglobinopathies, other things can have a macrocytic hypochromic anemia, other conditions like genetic defects, also hereditary transparent anemia. These are all conditions you should think about once there is no response to that. Of course, blood loss is always a major concern to our populations. So with this, I will summarize my talk. The important point of iron deficiency or any anemia, that is, anemia is not a symptom, it's a manifestation. It's not a disease, it's a manifestation of a disease. So we should look for a primary cause. Same thing happens to an iron deficiency also. Once we confirm iron deficiency, we should always look for what is the primary cause of iron deficiency anemia. So that is first thing. Second, of course, we should differentiate iron deficiency anemia from other microcytic hypochromic anemias. That is, to differentiate these before planning for iron deficiency anemia. Moderative times iron deficiency anemia, easy to diagnose, but it's always sometimes difficult to diagnose anemia of chronic disease or concomitant iron deficiency anemias and anemia of chronic disease. Iron deficiency typically causes low serum iron, high TIBCs, and low serum ferritin levels. And most of the times, oral iron is the standard treatment. It's cheap, and we have a long-term data with oral iron therapies. But whenever there is IV iron, now because of the newer IV iron therapies are possible with less side effects, and if there is a definite indications, we should consider it early if it is necessary. I think with these, we can stop our discussions and thank you very much.
Thank you, sir. A very exhaustive presentation indeed. You have nicely highlighted the clinical presentation, diagnostic modalities, and treatment options for the iron deficiency anemia. I don't see many questions in the chat box, so I have a few questions for you, sir, for the discussion. So my first question will be, how can iron deficiency affect the diagnosis or detection of thalassemia trait?
Yes, that can. So that most of the times, if you see especially HPLC, I have a strong suspicion. I think we should give iron therapies and also subsequently do HPLC. Okay.
So after how much time should we do the HPLC in such cases?
I don't know exactly timing, but at least 4 to 6 years of iron therapy is necessary.
Okay, sir. So you highlighted about evaluation of patients having GI losses. So if a female patient who presents with increased menstrual bleeding, do you investigate for bleeding diastasis also in such cases?
Normally, if it's a history of menorrhagia, it's not an uncommon finding in iron deficiency as etiology. But we should look for the causes of menorrhagia. Normally, it's a pivotal menorrhagia, younger age, and we should take history and look for any other bleeding other than menorrhagia. But sometimes it happens in younger age, which puberty menorrhagia persistent and causing iron deficiency significantly. If there is no gynecological other causes, we should always look for a bleeding diet, especially VWD, to rule out cause of menorrhagia, because one of the major cause of iron deficiency in young females is puberty menorrhagia, and one of the cause of puberty menorrhagia is bleeding diastasis like VWG. So normally you do investigate them, provided they are all cleared from the gynecology.
Sir, there are a few questions in the chat box. Harsh has asked, what is the dose of iron sucrose and how long do you give it?
Iron sucrose, normally we give dose total body calculations, and we do in once or twice maximum dose. Most of the times we use now iron carbomaltose. Okay? So we can use not sucrose nowadays, but because it's safe, sucrose is also safe, but we can use around normally ampoules are available around 500 to 1,000. Normally give around 750 microgram per kg, a milligram per day IV, and subsequently we should not give more than at least 1,000.
So that was about the iron carboxymaltose. Iron sucrose, 100 to 200 milligram. 200 milligram. So maximum 200 milligram in a sitting and given over 7 to 10 days total. So
yes,
you can give it daily over 7 to 10 days, 100 to 200 milligram. So Sylvia has asked, is RDA, RDW the first changes of IDA?
No, not like serum ferritin, but early sign, again, one of the early sign of early changes you can see in iron deficiency anemia, especially before microcytic hypochromic anemia, because you usually have a different size of red cells you can see just before a frank microcytic hypochromic anemia, but definitely serum ferritin is the earliest. Anemia that's possible, but not like iron deficiency.
So it might be first of one of the earlier changes you can see in iron deficiency.
Anemia.
So bone marrow findings in the iron deficiency anemia.
Normally you do iron store in this doing iron stain and to look for the iron stain in this patient by doing a bone marrow.
You normally get micro normoblastic kind of a picture with almost absent iron stores on the Pearlstein. Yeah. So what will the cause for poor response to oral iron therapy in pregnancy in other patients, including children?
So major disadvantage of iron therapy is tolerability and compliance. Okay, especially in children, they don't take regular iron, and same thing happens with pregnancies. So that's the reasons in the second, third semester, we prefer to give some IV because already they are nauseating, and then most of the iron deficiency anemias, oral iron therapy can cause severe GI disturbances. So apart from these, especially children and pregnancy stage. Okay, apart from this, if the compliance is good, then should not switch to IV iron.
Maybe in children evaluate for celiac disease.
Yeah, definitely. That I've discussed. Around 5% of patients you can have a celiac disease, especially in children. Okay, even if there is no history of any diarrhea or anything. Okay, GI symptoms may not be there sometimes. So even if that, we usually look for that to exclude celiac disease and other things.
And then there is a question about if even after 3 months of therapy, there is not full correction, especially what to do. I think they can continue with the iron therapy as long as the patient is tolerating well.
Yes. Yes.
Dr. Siaram has asked about safest IV iron preparation.
So I think most of these, except Destran, iron sucrose is also safe, but I think we are most of the time to use carboxymaltose nowadays. Okay? But I think even sucrose is also safe.
Yes, sir.
Normally we do monitor that.
So the larger iron preparation like carboxymaltose also or iso multidose and sucrose, they are all safe. Then Dr. Nakul has asked, is there a target ferritin before stopping iron therapy?
Target ferritin before you decide to stop supplement. Okay.
Yes.
Normal ferritin should be the level. I think more than 1. There is no level. Normally you should give 3 to 6 months, but you can do ferritin levels at least more than 100 there.
So Dr. Nakul, usually correction of hemoglobin, we give iron. We should give iron therapy for at least 3 months more to supplement the iron stores. So someone has asked, anemia patients have splenomegaly. Splenomegaly causes anemia. Sometimes both coexist. What to treat first?
Frank, iron deficiency anemia usually not cause iron deficiency, splenomegaly. So I've said very few, less than 5% of patients can have a splenomegaly, untreated iron deficiency anemia and on mild splenomegaly. So once there is a splenomegaly, you usually think about this, what is the other conditions, what are the other causes of splenomegaly. So most common cause with a massive splenomegaly with iron deficiency significant many comes to mind is usually any portal hypertension and there is bleed or GI loss were causing secondary anemia. So we should not think about the two separate things, anemia and splenomegaly. I think we should try to collide both, have a uniform etiology to explain the both conditions. As I said, like portal hypertension, chronic liver disease, and iron deficiency. So whom to treat first depending upon the disease. So once you know the two causes, splenomegaly cause and iron deficiency, simultaneously treat anemia with iron therapy and also look for a cause of splenomegaly.
Yes, so iron deficiency being so prevalent can just be a bystander in so many of the cases. It could be just diagnosis or may not be contributing to splenomegaly at all.
Exactly, especially elderly populations. Those are patients like old people present with massive splenomegaly, maybe other conditions, maybe we are looking at a marginal lymphomas, but majority of old age patients can have iron deficiency component. So we should always think about two separately.
So then there's a question about septic patients. Can we give oral or parenteral iron therapy in them?
IV iron sometimes precipitates. There is you can avoid if there is possible if there is no contraindication. So there is no complete indications, but I think try to avoid during a sepsis is there or not.
So iron can cause increased free radical damage and toxic oxygen.
That precipitates.
Yes. Yeah. So we can avoid giving IV iron during septic times. Maybe when the patient is more stable, you can consider IV or oral iron. So then I'd like to ask, how do you manage GI toxicity of oral iron therapy?
Okay, we try to give, as I said, to modify your dry intake or especially oral intake between foods and avoid do that. And we try to reduce the dose. Sometimes, as I said, frequency of iron therapy can be maybe alternate days or low dose. That is also another option to think about to at least have a good tolerability and compliance. And apart from that, encourage oral most of the times. And if there is oral is not possible, I think you can consider about that.
So we should usually avoid PPIs and other drugs which decrease the absorption.
Yes, that I will.
So I think there are no further questions, sir.
Anything missed, just check that.
Yeah.
fuse, I think there is in between there is more.
Yes, sir. So we have discussed almost all the questions which are asked.
Okay.
Thank you, sir. Thank you for a wonderful.
Thank you. Thank you very much, everybody. Thank you for joining. Thank you again.